At our core, we are an advocacy organization that is committed to catalyzing partnerships with government, health system influencers, business and community leaders to understand barriers and gaps and to challenge an unconscious bias in women's health. I am so pleased that the government of Alberta has made a conscious choice to stand up for women's health, to declare this week Women's Health Week in Alberta, to engage in collaborative discussions, and to join us to wear red, period. This declaration was released, this morning, and here to bring a message about that is Minister Shandro.
Hi, I'm Tyler Shandro, the Minister of Health, and today I'm proud to declare May 8th to 15th as Women's Health Week in Alberta. Now, this is the first time in Alberta and in Canada that government is dedicating a week to raising awareness and greater understanding of the unique health needs of women. And Alberta Health recognizes the importance for women of all ages and backgrounds to have access to reproductive and sexual health services. And these issues are not always understood or talked about, leaving women who face their unique health challenges alone. And women's health issues are unique, and women should feel safe and they should feel supported in discussing their issues with their healthcare providers. And when women don't seek help, they may not only experience serious health challenges, but also psychological trauma and increased risk of chronic disease. And that's why the ministry is working with Alberta Health Services to improve reproductive health services and outcomes across the province, especially for vulnerable women. And that means improving the experience that women have when they do access the healthcare system and providing choice, providing treatment options, and focus on proactive health management for women's health concerns. And we've made targeted investments to do just that. Alberta Health provides over $2 million in annual funding to 5 community organizations across the province. And this funding supports vulnerable women who are pregnant or of childbearing age. And on top of that, $4 million annually goes to community-based organizations. This inaugural Women's Health Week, I encourage all women in Alberta to access the many health services and resources provided by Alberta Health Services across the province. And online resources can be very useful for educators and parents who need to communicate to children and youth. And if you are a woman and have concerns about your health, please reach out to your healthcare provider. They're there to listen. And your healthcare system is open and ready to help. Thank you and take care.
Nice that we get that message, those video greetings. It's very interesting times right now when session got canceled unexpectedly, and visiting offices and getting together in person is not easy. Yet I have met with Minister Shandro this week and several other elected officials. I want to just very quickly read the declaration, and you can find it on our website as well. The declaration reads, whereas women with menstrual, sexual, and reproductive health challenges often face them alone and may not discuss their concerns with their healthcare team due to embarrassment or fear their symptoms will be dismissed or normalized. And whereas poor reproductive health may result in stigma, unintended pregnancies and abortions, sexually transmitted infections and HIV, psychological trauma, cervical and other genital cancers, and increased risks of chronic disease and infertility. And whereas the government of Alberta has made targeted investments to improve reproductive health, particularly for vulnerable women, and is committed to addressing gender bias gaps and barriers for women in accessing the health system for their unique health conditions to improve their clinical experience, treatment options, and outcomes. And whereas the Women's Health Coalition brings together healthcare professionals, community leaders, and women advancing open dialogue, learning, and engagement to address menstrual, reproductive, and sexual health so that more women experience a healthy life. Therefore, the Honorable Tyler Shandro is proud to declare May 8th to 15th, 2021 as Women's Health Week in Alberta. I think that message reinforces a lot of things about how important it is to work with government. And it's a fabulous way to kick off the week of better conversations for better health. Women's Health Week is a province-wide initiative anchored by Mother's Day, quite intentionally. For 1 week, we will focus on raising awareness and increasing understanding and engagement about women's experiences in sexual, reproductive, and menstrual health throughout their whole life journey. We know we are gaining ground when women can tell their story and guide their healthcare experience with more authority. When we see signs that the stigma and gender bias associated with menstrual, reproductive, and sexual health is lessening. When workplaces are prompted to examine policies that may inhibit open dialogue, or they create programs to encourage more open interactions. And the healthcare community pulls together to embrace women's health as a priority to ensure the system is accessible, easy to navigate, and patient-centered. We know we are heading in the right direction when we can foster collaboration between community leaders, healthcare professionals, and government to address barriers, gaps, and the unconscious bias in sexual, reproductive, and menstrual health. That's the difference we want to make, and it starts today. The Women's Health Coalition advocacy efforts will be influenced by women's stories, informed by healthcare professional expertise, and advanced by evidence-based recommendations to government and health system influencers. We can only do this with committed, influential, credible partners. I would now like to call on Dr. Sudha Coppola to bring a message on behalf of the Alberta College of Family Physicians.
Thanks very much, Carmen. The Alberta College of Family Physicians commends the work of the Women's Health Coalition of Alberta and their leadership and commitment to women's health as a whole. For Women's Health Week 2021 and for the Women's Health Coalition of Alberta's ongoing advocacy efforts on behalf of women in Alberta, the Alberta College of Family Physicians offers its support and very best wishes for this coming week and ongoing. Thanks very much, Carmen.
I am so looking forward to working with the Alberta College of Family Physicians. They are committed on so many levels and definitely have an appetite to change the conversation about women's health. So thank you for joining us this morning. We have another partner that I certainly am glad could join us this morning. We wouldn't be here today, quite literally, if it wasn't for the unwavering support and commitment from the Alberta Construction Safety Association. I'm so pleased that Tammy Hawkins can join us this morning on behalf of ACSA. Tammy?
Thank you, Carmen. Good morning. We have to sort of adjust the mic for a moment here, a bit of a height disparity. Good morning, everyone. I'm thrilled to be here on behalf of the Alberta Construction Safety Association. We just are loving partnering in any way we can with the Women's Health Coalition and the amazing work being done on behalf of women's health. Our focus here is health and safety sometimes gets the lion's share of the attention in this industry. So to have this attention to health, we're just thrilled about it. Thank you so much for your amazing work. And that's really it for me. I'm looking forward to Dr. Singh.
Thank you, Tammy. The Women's Health Coalition is entirely made up of volunteers who have done an amazing job of raising awareness of the issues, creating a brand for the Women's Health Coalition, and establishing advocacy priorities. You will meet the team at the end of the webinar, but one of the women that has been instrumental since the very beginning in making this possible is our Vice Chair, Paragi Shah. You can check out her story on our website, but today she has the privilege of introducing our webinar speaker. Paragi, over to you.
Thank you so much, Carmen. So you're right, introducing Dr. Sony Singh is truly a privilege and someone I've actually had personal experience with during my navigating my own journey with uterine fibroids. So definitely, I'm very excited to do this today. Dr. Sony Singh is a professor and fellowship director within the Department of Obstetrics and Gynecology at the Ottawa Hospital and University of Ottawa. He's also the Dr. E. Jolie Research Chair in Gynecologic Surgery at the Ottawa Hospital Research Institute. Upon completion of his medical training at the University of Western Ontario, he completed his fellowships in minimally invasive surgery at the University of Toronto, as well as at the University of Sydney in Australia. He has developed nationally recognized tertiary level clinical practice in complex surgical gynecology. He's also the co-founder and the past executive director of the Canadian Society of the Advancement of Gynecologic Excellence, which is also known as CANSAGE. And also to help colleagues and trainees and patients, Dr. Singh has helped disseminate gynecologic, surgical, and educational principles nationally as well as globally. He has over 250 invited and 200 research public presentations worldwide, 50 formal courses, and over 150 publications to date. Busy man. Within the national level in Canada here, Dr. Singh has taken an active role in supporting gynecology education and clinical care, which also includes direct benefits to women and clinicians within Alberta. So here to tell you more, and Women's Health Coalition welcomes you, Dr. Sony Singh. Please, and over to you.
Great. Thank you so much for the very kind introduction. And before I get started, I just want to make sure I do a tech check. Can you see my slide? Fantastic. Thank you, Paragi. Thank you, Carmen. Thank you to the Women's Health Coalition. I'm so excited to be here, and I hope for the next hour that we can have an intimate discussion about something that I'm very passionate about and have focused my whole career on, which is women's health care, and from a gynecology perspective, of course. And I'm so excited to see family medicine supporting the Women's Health Coalition as well, because again, it takes a team. It's never an individual, and we need as many individuals involved to create that team. So without further ado, we'll go ahead and get started. If I have the thumbs up from Carmen. Cool, great. So I'm just going to start moving the slides ahead. So number one, I have my shirt. I hope you have yours, to make sure that you remember to wear some red and support this cause, but also women's health in general. I think I reflected on the importance of having a background like this, wearing the t-shirt, but also showing support. I think the overt support that we need to show in these situations is of the utmost importance, because I think when I go and speak and whenever we have a chat about these topics, often I'll hear the importance of recognizing, of talking about these issues and being open about them. And I think patients really like it. Partners, families really appreciate it because it starts to normalize the discussion. So again, thank you so much. Here's my disclosures. So I have an active research group at the University of Ottawa, at the Ottawa Hospital, but I did not receive any payment for this presentation. I got a t-shirt though, and from industry or anybody else, and these are all my own perspectives. So I hope over the next little while, we're going to identify the current challenges faced by girls and women in Canadian setting. We're going to review some common gynecologic conditions and the current state of care. And then I'm going to offer you some suggested solutions that we've certainly done some research on, but I wish we had more momentum behind. And I think in Alberta, this is the time. You are at that moment of change to be able to do so. The underlying theme will be that the most common gynecologic diseases that affect girls and women of reproductive age have been forgotten or ignored. They are things like uterine fibroids, endometriosis, symptoms of heavy menstrual bleeding, and of course, pelvic prolapse and incontinence. The other theme is that we need to figure out how to navigate a very confusing system for patients and physicians. So going back to family practice, I was on the phone yesterday with my colleague in family practice as we were trying to find the ideal care for a patient who is really struggling and trying to figure out how many referrals have to be sent before they actually get accepted. So why do we even need to discuss this? Well, we need to discuss it because these young individuals are children. I have a daughter and 2 sons. They have a whole life ahead of them. And it drives me or drives my passion to understand that we can make a difference early on in the life of an individual. And when I do see patients as I grow older with them, or I see them later in life, I wish we could have intervened earlier to show them that they could have had a life or a better quality of life. And that's where my passion and dream come from. So just to give you an example here, this is an article that we wrote, something called the life course impact of an individual. So on the y-axis, you'll see achievements in education, family, career, and then along the X, you see where that point would be in one's life. So starting on in life, we have our innocent children who are just open to any and every opportunity. We tell them this idea that they can do and be anything that they want to be. And moving forward as they study and as they build their career or hopes and dreams, we support them ongoing. And the hope is that my daughter, my sons will be able to achieve that dream and that nothing will interrupt it, so that whatever that dream is in the future, no matter what pandemic shows up or what happens, that they can achieve that. Now, just in terms of periods, I'm going to share a video with you. And if we don't hear the sound, let me know, but we've just tested and it worked out okay.
First, Jenny got it. Then stupid Vicky got it. And I tried everything to get my period. Nothing. So, I faked it. Looks like Florida. Yeah, I got it. It's so red. Cherry Slush Club. Blood Sisters. They bought it.
Hey, Katie. What's this?
What do you think it is? I'm on my ladies' days.
What do I think it is? Rubylicious nail polish. But she doesn't need to know that. We have to celebrate.
No, we don't.
Oh, it's family tradition. We're throwing you a first moon party.
What the hell is a first moon party?
Oh, it's one thing to lie to me, but to take that tone, it's on. Hi, do you make vagina cakes? Hello?
Then, people started showing up at my house.
Grandpa, great to see you.
Oh my God. You're so grown
My
up.
grandparents, my friends.
This is so weird.
Good to see you.
My mom's friggin' coworkers.
There she is. Hey, I got you the super pack.
These are coffee filters.
Yeah, I wasn't sure what brand you liked.
I just didn't expect my mom to be such a freak.
Pin the pad on the period. All right, separate up.
Pin the pad on the period? Seriously?
Do you know how hard it is to find a uterus pinata?
I used to like marshmallows. Not anymore.
This next one's for Katie and the weirdest birthday party ever.
Mike, drop.
I'm a queen bee, come get it. No
When things couldn't get worse,
surprise!
my dad showed up.
What are you doing? You're missing the magician.
You need to stop this. No one is having fun.
What are you talking about? This party is a hit. Your grandpa is bobbing for ovaries like a champ.
I faked it.
Well, maybe you should open this first.
Period starter kit. Aren't you gonna ground me for lying?
Why do you think I threw you the first moon party?
So I wanted to share that because I, want to make sure that we're open to talking about periods. Just be glad, I guess, you're not my daughter. And realize what kind of conversations we have at home. And she does not want to talk to me about it at all. But the point being, this should be a celebration. This should be something that we recognize and talk openly about. Yet that isn't the experience that I think most people would have. That isn't the way in which we view periods or menstrual health or reproductive health in general. And so imagine we take that one step further, that we're not so open, that we are quiet about it, and that's fine. But what if something happens? What if instead of celebrating, something disrupts that life's potential as we move forward? What if a symptom or a problem develops, and then as you see it, we'll go through numbers there, that life potential is interrupted because you can't make it to school? Suddenly it's not something to celebrate, something it's to avoid going to school or seeing your friends, or the fear or embarrassment of an accident. As you go through life, imagine not being able to realize that career path that you had hoped because you just were missing too much school or not able to make it to that job interview. Forget about sex because of the dysfunction that would come with that, or the pain that results, the trauma that results. You know, once you're in and finally have a career or a job, you can't get promoted because you're seen as the one who misses work, just happens to be every month at the same time. Difficulties conceiving, the stresses that happen afterwards, you know, the issues with getting pregnant. And of course, finally, menopause comes around, hoping that all this will be over, yet to realize that there may be more issues. So that impact on the life course is so important to identify. And this article that we wrote actually had to do with one condition called endometriosis. And where is it that we can interrupt that issue? And it starts with talking about it, identifying it, and see what we can do so that we can avoid these impairments, like reduced productivity, which will affect many different areas, not being able to sleep, fatigue, which I'm going to talk about, how that interacts with everything and every part of being an individual or a person. So why do we need to discuss it? Because we need to realize the full potential of every individual that is born with a uterus or ovaries, and we want to be able to see that we don't have the same barriers that are there today for the future. So it's our mission, it's my mission. Here's another video I'd like to really share with you, a little bit more graphic, but not in the way that you may assume. So that was quite an old ad now, relatively speaking, by Lebras, the company, I believe out of France. And it's just, it sticks with me that it really hits home that point of that potential. And we often, as a society, have had our own biases towards what makes a girl or a woman, obviously, you know, versus a man or a boy. And of course, I will at the end be happy to discuss even between that and being more diverse, which is ultimately very important. But the point being that there should be nothing that should have to hold an individual's potential back, especially if it's treatable, especially if we can do something with it. So let me get into some practical stuff. I'll talk about what I know, which is my everyday practice. One of the questions I often get is, you know, periods are there. How do we even know when there's an issue? Well, there's some factors that come into play. If it's super heavy, painful, irregular, if there's bleeding or issues after the menopause, and of course, if there's difficulties getting pregnant. So to give you some examples, I'm going to start with the most common presentation we don't talk about at all. And it's incredible how we don't want to talk about something that affects so many, which is heavy periods. So did you know 1 in 3 women on average are affected by heavy menstrual bleeding? And then of course that impact on their social, sexual, and physical well-being is there. That's incredibly common. And when we're talking about it being 1 in 3, we're not talking about, and we often have dismissed, you know, what does she mean by heavy? Oh, you know, we all have heard about heavy periods before, but we are talking in my practice, hemorrhaging. I've had the example given to me from my American colleagues that their patients would say it looks like a murder scene. our societies obviously have different reference points. But the issue is that it is so devastating, the amount of bleeding that these individuals are struggling through. Yet in an international study, half of those surveyed had no or very little knowledge that that was a thing, that heavy menstrual bleeding. 39% were unaware that there were actually treatments. And of those who actually in that same study were tested positive for heavy menstrual bleeding, 35% of those knew nothing about this being a condition that needs to be managed. And in fact, in that similar type of study, half of those with heavy menstrual bleeding actually received no treatment. We're on no, not even anti-inflammatories, which reduce bleeding by up to 20% alone, nothing. So what is it that, why is this happening? And this is again from one of my colleagues, Dr. Erica Marsh, who has done some great qualitative research and small group discussions. And one patient in their, or subject in their group said, this is what you go through as a woman. And it was like every month you were going to bleed half to death. And then the rest of the time you're almost okay. I just went with that. You know, it didn't kill me, so I would just be stronger. You know, when I talk to my patients, this is a story I hear over and over again. You know, yeah, I'll deal with it. It's only a few days a month. But the rest of the month, when they're so anemic, that is a low blood count, and they're not functioning as well as they potentially could, I often tell them, once we correct their issues, they're going to feel like a totally different person. That forgetfulness that you just put out to being due to, you know, getting older, the hair loss, again, due to, you know, not eating as well, or whatever other examples, were all due to that massive hemorrhage and bleeding every month. So where do people go for education at this point, or trying to learn more when they finally do realize there's an issue? Well, they go to the internet. And this has been both excellent, but also a problem. And so I'm glad webinars like this are occurring so that we can get some accurate information out there. And right now that is probably more utilized than going to any physician at this point, simply because of the pandemic. So a group of us across the world developed a website called heavymenstrualbleeding.com. Again, my kids were really excited that I was going to be building a website. And then when they heard the topic, they quickly left the room. But it was an excellent opportunity for us to advocate. This was the old web page, which I got them to get rid of because I didn't like myself being on the cover there. But we had a patient site and a healthcare professional site, and it's been updated just recently, actually. And on that site for the patients, we have patient stories, we have information for patients on what to expect when visiting their physician. And I'll just give you a little example here of a story.
What do you call your period?
Oh, nightmare?
Red Army.
Red Army.
Yeah. What's the best thing about your period?
Oh, really? That's the best thing?
When they end. Okay, so what's the worst thing about your period?
It was every 3 weeks, and it's like solid. There's like no relief.
It's terrible. You can literally go and put a tampon on or a pad, and then within half an hour, sometimes less. Usually I get away with an hour. You're all done.
It's a lot of work.
It is a lot of work,
Yes.
yeah.
Why is having a period a taboo topic?
It's messy, isn't it? Like, who wants to talk about blood, really?
So I won't go through it all, but this is all available. And it really helps encourage them. These were real people, by the way, who had real stories. It weren't actresses or actors. And I think it was very important for us to hear these types of dialogue. So on the website, heavymenstrualbleeding.com, individuals can access a little calculator to just show how many days a month, and then ultimately a year they're bleeding, what kind of activities they've missed. The cost alone of menstrual hygiene products is tremendous. You know, in my own clinic here, I realized a few years into practice, I'm at the Women's Health Center at the Ottawa Hospital, we actually didn't have any pads or tampons or anything in our bathrooms. All of the bathrooms were identified for our patients, but when you walked in, there was actually nothing. And that's crazy. Here I am dealing with heavy menstrual bleeding patients, and they had to basically come and ask us if they could have a pad. In the hospital, they're the worst ones ever. But with my research program, all the extra pads now, we make sure it's available and make sure that patients have access, but simple things like that. So you can also hopefully get to some frequently asked questions. But let's take another pivot now to say, on the website, that's great, and trying to get accurate information. But for some of you who out there wanting to learn more about this topic, one of the most common questions is what causes heavy periods? So let's go into that. There is an international push, which is now a decade old, and believe it or not, still not adopted, that breaks down the causes of heavy periods or heavy menstrual bleeding into structural causes or non-structural causes, called the POM coin. And you can see that there's just a tremendous number of causes. But I'll be honest with you. In medicine, when it came to evaluating the uterus or these causes, we were never taught to be as systematic or as thorough as I was taught to work up GI bleeding, so from the colon or the bowels, the bladder, or any other system for that matter. When I was in medical school, we were taught, it's got heavy bleeding, do a D&C, offer a hysterectomy, or there's a new thing called endometrial ablation you can try. That was it. Have we come further? Yes, in talking about it, trying to raise awareness. The adoption of this approach has been very slow, to say that there's such a complex system of hormones, of organic pathology, of other issues, things we don't even understand. Why not study it? Why not evaluate it in the way it should be? Another big point that we just published in a study just recently from a national database that we had was that imaging alone in Canada is terrible. So when an individual gets an ultrasound, the quality in one place versus another, is so different. I'll get an ultrasound from a place which will say fibroid. That's it. Uterus and a fibroid. No comment on the location, size, or anything else. And that's acceptable at this point. Whereas if you had to look at the colon or the bladder or the lungs, you didn't know exactly what kind of nodule you were dealing with, what the differential was, how to treat it, what you would go for. So what happened? Why did we ignore all this? Why was there such a miss on trying to manage these cases? So uterine fibroids are just one example of the most common causes of bleeding that actually have a disease state or finding, and they can occur in the muscle of the uterus in many different locations. And trying to pinpoint the location is essential to treatment, is essential to care. And yet fibroid mapping isn't something that is done routinely. In fact, there's very few people actually doing research in Canada alone on this topic. It kills me. So uterine fibroids, let's talk about them. 50 to 80% of those with a uterus would have fibroids. And you'll notice that a lot of my pictures have women of African diaspora because they are disproportionately affected, closer to the 80%. 50% is what we would say for Caucasian women. And of course, the rest of the ethnic backgrounds or racial backgrounds aren't even mentioned in the literature, which is even sadder because we've only looked at this at the first level of the iceberg or the tip of the iceberg. So fibroids can grow and they're usually benign tumors, but this has been the worst disease in gynecology, I think, during the pandemic. These women are struggling. They've often already delayed access to care or understanding. Remember that ultrasound that just would say fibroid, if even that, that was in some report somewhere. Accepting heavy menstrual bleeding or that you're gaining a bit more weight. Yeah, that's super, super common. So this is a graphic photo. Actually, I should stop before and warn everybody. So if you want to turn away, the next patient who has allowed me to share her story for many years came to us with a belly the size of a full-term pregnancy, so 40 weeks. And my colleague actually asked me to help with this case, saying, I've got a small case, can you just come and help me? So when I walked in, lo and behold, here was this uterus filled with fibroids, massive, and she had lived with this forever. So if you don't want to see it, look away. And I did ask Carmen Piragi if it was okay. And they said, you know what, we have an interested group, so why not? So here is a shot of the uterus brought out of her abdomen. So you can see the size relative to my hands. And I'll just push pause. You can't actually see the uterus. This little white thing here is an ovary. This is a fallopian tube, but you can't actually see the uterus. The rest of all this is fibroids. It really does look like an alien. So if you think that's a lot, just wait a second when you get the shot from the other angle. There's even more behind. And this is after we've removed the fibroids, so the uterus will hopefully shrink, and that is after we've cut them out. There were 68 fibroids in there. This poor woman suffered for years and accepted that this was going to go on because she had developed an altered perception of what was normal. This was her normal. In Canada today, with the pandemic, when we stopped surgery, this was and still is considered an elective surgery. In my practice alone, where we've got 200 cases waiting to be done, and I don't do any primary care, I don't do small cases, these are the types of patients who are waiting for surgery and struggling and suffering because of the thought that this is normal. And again, this is from Erin Marsh when she did the qualitative research to say, it's okay that I flood and soil my bed every month because that's what everybody in my family had happened to them. It's okay that I look 8 months pregnant because that's, you know, all the doctors have told me that you have to live with that. You know, this is insane. Another qualitative article by the same group says, had a patient quote that I really like. I think that there's an aspect, oh, it's gonna go back. I think that there is an aspect to having fibroids that some women feel that is a secret topic and you don't discuss it until you've had the surgery. I think there needs to be more communication so women feel comfortable just to talk about it. Please, just let's talk about it and let's just get moving. A new concept to me, because I didn't even think that this was even something that we should even talk about, because again, I came from a system where fibroids meant hysterectomy, maybe removing a few, but this is something that people live with. Is the ideal that we can create centers of excellence, which would be providing multidisciplinary care. Currently, they exist for cancer care, or they may exist for other complex conditions. But when you've got these crazy situations coming up, we need a fertility doctor, a hematologist, we need surgeons, we need imaging people who are expert, so that patients can get the best evidence-based options for them. We need to provide them emotional support. Many suffer a loss if they end up having to go with a hysterectomy. And that may be the only choice they have, but they need that support to say, you're no less an individual after this. They need to feel included. And of course, we need to engage the community and others as well. One of the most positive things that has come out of trying to push the fibroid care awareness so that eventually we have the right choice for the right patient at the right time is that there is attention internationally for this topic. And I think advocacy is the key. I can talk about it later, but to be honest, in the US, it's been amazing that Kamala Harris actually was the first person to propose something called the fibroid bill, which after she became vice president has now been handed off to others so that there is going to be investment nationally in the US for fibroid research, despite this being a huge problem for many years. It's the #1 cause for hysterectomy. And they've done the same thing with other conditions. So this condition needs to be managed. I always felt shy or crazy that I was making something out of, that wasn't as big a deal, but no longer are we going to be silent. This is a huge issue. And the pandemic really, really brought this to light as these women are flooding and suffering at home. I've got them on IV iron weekly or every other week. I've got blood transfusions happening as they struggle. So I'm just going to stop there and make sure that our time check is okay. It is, I think we still have a good 15 minutes or so, and I'm going to keep going with that perspective. So that's good there, Carmen, time check wise? Perfect. So let's just move to the last section, which is on what happens when periods are painful. So pain, chronic pelvic pain is a key symptom of a disease called endometriosis. And here are some of the symptoms that individuals with endometriosis would have, but painful periods in general are the other half of my practice. So pain during the period, before the period, pain with intercourse, pain with bowel movements. It's a massive undertaking that the country, again, is lagging behind in. And overall, we expect that of those with chronic pain, up to 20% will have endometriosis as one of the conditions. And I'm going to define endometriosis for you now. So endometriosis is where tissue like the lining of the uterus, not the lining of the uterus, because if it was, then we'd have a different discussion. This is a condition where disease implants itself. So on the right, you'll see a surgical picture from my files. There's the uterus. There's what we call a grasper, just holding things down. The ovaries, you can't see it in the bottom there, but those black spots are the spots of endometriosis. And I'm showing you more of a milder case, but this disease can then invade into the bowel, the bladder. I deal with cases invade into the diaphragm to the point of bowel obstruction, kidney death, and obviously severe dysfunction in their quality of life. It affects 1 in 10, we think. It definitely affects more. That is just old numbers that we have. In those with painful periods, in those with infertility, it's much more prevalent. So we have to think about that. The saddest thing is that most symptoms started in a young age. In my own practice, when we looked at a select group of 100 patients prospectively, we found out that most of their symptoms started at age 15 or 16. You know, I can't believe that my daughter or yours or others' children would be subjected to the lack of care or access simply because we just didn't want to talk about periods. It's complete BS. And I think that that's what, again, drives me. So I talked a little bit about the advocacy around the world for endometriosis. Orrin Hatch and Elizabeth Warren actually did a public service announcement about a year or two ago. And they got together to speak out about endometriosis because I believe Orrin Hatch's daughter struggled with that. In Australia, there was a national action plan for this condition, which is incredible. The Minister of Health at that point actually publicly apologized to women for not acknowledging endometriosis for all those years. They are one of the most advanced national action plans in the world. And guess what? We don't have that plan. So we continue to struggle. Not only do we have marginalized population due to poverty, due to ethnic background, our northern communities, our First Nations communities who don't have access, but our rural communities. And it doesn't even have to be rural. The Maritimes, for example, are an area where endometriosis access or care for that more complex condition isn't readily available. And this was a patient who was featured in a CBC story a couple of years ago, where, you know, she expressed that struggling with pain and lack of access was a challenge and a burden to her, but not just her, many, many, many women. The problem with endometriosis is that when you look at this, you can't just think of it as one condition, but rather that it overlaps with many different issues. And that's why one of my recommendations is going to be developing centers of excellence where you really need it. So we've published a few studies. We've done national surveys on this. There was a 30,000 women who are part of this online survey group, and 2004 self-reported endometriosis. And they validated that, yes, painful periods and pain with sex actually were the two most common symptoms. But I want your attention to go to the impact on fatigue, the burden that these individuals are living with that you don't see. My patients often tell me, and I see it, that they are not able to express the internal pain. They're well put together, they're working, but they hide it all inside. The amount of anxiety that goes in to trying to hold some of that symptomatology is significant. And so for you, for those of you out there in the workforce or advocates for the workforce, like our partners in construction, 42% said they had an impaired work ability or 46% overall work impairment. And 17% have had work hours missed, and it affects their daily life in many of those cases. And look at the ages that are affected. This is our most productive age group. These are our doctors, our nurses, our everything, construction workers, our pharmacists, and it's affecting every part of their life, and yet we haven't even talked about it. Many can't even say the word endometriosis. Of those women, and here's a separate study looking at that same population, 1/3 said they weren't even treated. So many were taking over-the-counter treatments before being diagnosed, and then after treatment, really, there weren't many options provided to them other than surgery. And many had multiple surgeries, including our friend Lena Dunham in the US, who is an actress and producer and director. And if you ever want to find out about her story, she's had significant numbers of surgeries. I think at least over 5, if not 7 now, and every organ slowly being removed to try to ease her pain. And really what she would have benefited from, we think, again, I don't know her story in detail, was a multidisciplinary approach early on in her life to mitigate what became chronic pain and this tragedy of multiple unnecessary surgeries because of not having that ideal plan. And Jason Abbott is a professor in Australia who led that action plan in Australia, who talks about the fact that patients with endometriosis need better help. And because our meds and our drugs currently are not perfect for one person. And in Canada, we don't have centers of excellence for this outside of the University of British Columbia, which has obviously a geographic limitation and limitation to serve who they serve. So we have to come up during the pandemic with strategies of helping patients cope at home. I think this was a great, this is an infographic made by some medical students in an article that our colleagues across the world had put together. And actually it was great. We're gonna help patients understand what they can do at home, not just for the pandemic, but in general, because frankly, many don't have access to care. So educate, help, but please, when they finally need it, we've got to open some doors for them. They're struggling, they're searching, and they don't have access. So in my last 5 minutes, I'm going to just go over some ideas that I have for improving the situation overall. I think that, first of all, I've made the point that we need early identification and education. We need better and more accurate diagnostics, because frankly, we just haven't done it. And I blame the practice of medicine. I blame gynecologists and physicians in general for allowing this to continue. Essentially, I take the blame on in part myself. At the same time, I also have to hold accountable society, the patients or individuals themselves. We need to speak up, and we need to push this and not be apologetic that we're talking about periods, pain, fibroids, tumors, because that's what we've done too long. So whatever has happened, but we have to move forward. We need to create centers of excellence for conditions like fibroids, endometriosis, and pelvic pain. You know, that just makes sense. For some of the cases I do, we're the only ones in Canada doing them. in small numbers, you want to go to the best place in the country, and the government should support that. Some of the work that I've done in Alberta over the last 15 years has helped develop some of that. And we've trained fellows now to go and do some excellent work who have now are working in Alberta, but we need a national action plan for that. And finally, greater community awareness, where Women's Health Coalition definitely will play a big role as well. So the advocacy is growing. We have the Fibroid Foundation. If you want more resources on fibroids, a US group who are looking for chapters. It's a volunteer organization. You'll get training if you want to lead that, a chapter for more information in our Canadian communities. We talked about Kamala Harris's introducing the uterine fibroid bill. You know, just everybody has had these issues, but nobody's been talking about it. It's insane. Endo Act Canada, I want to put a plug out for them. You can look up, it's a group I'm a part of that is spearheading the goal to improve lives of those with endometriosis. Very inclusive. You'll see the word people, not women alone, because many are affected with endometriosis. But that is a national plan, and you can share your story right on the website, and hopefully we're looking to make a national plan and effort there. Obviously, none of this can happen as fast as I would like. My colleagues in BC, who really are an incredible group, got a fund grant to teach about menstrual health and painful periods and endometriosis at the high school level. And that's just exciting to hear that that kind of stuff is going to happen. But finally, we need to change the way the care is provided. So my ideal would be for any of these conditions that when awareness is achieved that there is an issue, family medicine and primary OBGYNs or general OBGYNs would see the patient and be able to manage them, and that's it. That's most patients. However, if they're not getting that result in 6 months, or it looks like it's more complex, that they can access within 6 months a local gynecology expert who has that experience or expertise. Finally, if it's identified that this is a rare problem, which I'm learning there's a lot of rare out there because it's only now being identified because we have better imaging and awareness, that you have national centers of excellence where you say, this is where we go for this. And it may be provincial at the beginning, it may be national for depending on the issue that we have. So as I finish up, I'm going to give you an example where we could make a big difference. I told you that we didn't really evaluate the uterus. Really, we didn't. So the bladder, you can get a cystoscopy at every corner, I feel like. You can colonoscopy at 10 different centers. Yes, there's waiting times. To get a hysteroscopy has generally been something you have to go to the main operating room, you have to put on a wait list, and that's just how we've always done it. The science and the skill set around hysteroscopy has changed tremendously. So if you can put a scope in the bladder and the bowel, how come we forgot in between the vagina and the uterus? It's insane. And this video that you're seeing on the other side there is a procedure we're doing in an outpatient setting without having to access the operating room or putting a patient under general anesthetic. And this patient is able to come in and this is all real time, able to have a polypectomy done and go back to work immediately without any general anesthetic. And that's something we've been trying to champion for many years. It was 2005 that the UK suggested that everybody should have access to this. And in Canada still, we only have a couple of centers across the country which have access to outpatient, not in the operating room, procedures like this. So we published a study recently looking at the cost effectiveness, because money talks, of comparing what it would take if you had a standalone unit where somebody who had heavy menstrual bleeding would go in 1 day, get an assessment, an evaluation, and treatment versus the traditional model. And the bottom line was we would save $1,300 per patient experience, and they would get care 75 days earlier. That's huge. So we did an infographic just so I can go over it with you. On the current care pathway, you see that you have to be referred, you have to go see your family physician, who then has to refer you to an expert after having ultrasounds done, which I just told you many times aren't helpful for gynecologists because of the lack of information. Get other testing done, and a certain percentage will be great because they're going to have primary issues and it'll be fine. But these are patients who needed ultimately other care and they need a referral. So then the family doctor has to figure out where to refer them, what the wait times are, and currently we have no access in many places. On the other hand, imagine that primary care could see the patient, try the first route of intervention, and if it doesn't work, be able to just send the referral to one place, which would then triage them into a uterine assessment and treatment unit, a UATU. Currently, in the referral process, the gynecologist sees them in the office, orders another ultrasound test, often repeating all the great work our family doctors did because there's the parking cost and other issues that come in. Finally, they book them for the operating room where you have to go visit the anesthetist beforehand. You have to make it a whole day. You're put asleep. You have to recover. A lot of craziness. Versus the other way of the uterine assessment and treatment unit, you come in, you get your hysteroscopy, your ultrasound, everything in one day, and right then and there you can get treated and counseled, and you're done. So a lot quicker, cheaper. It just makes sense. The system has been set up with barriers because of many self-interest, including the subspecialty of gynecology, including red tape that is unnecessary, including a lack of understanding how to improve the access, especially with my family medicine partners who are frustrated because they often will get rejections for referrals. Oh, I can't see the patient for a year, so find another gynecologist who then says, I don't do this procedure. It's a complete craziness. And I can't believe what our family docs go through, let alone some of our other practitioners. So here's an example of a success story from Alberta. So the division of minimally invasive gynae surgery has exploded out of Calgary, and it's all very new. So many of you may not even know this exists. But Dr. Rajakumar was one of our fellows, and the others are all people who've trained. Dr. Belland is actually the most senior person there who trained years ago in New Zealand, and others who are trained with the experience of being able to provide minimally invasive surgical skills. This is all very new, but there is investment, but there now needs to be awareness and exposure to see how we can grow this community. I am very jealous because I don't have this capacity. Everybody we've ever trained we've trained so that they can go work at other places, but that is a success story that can move forward. And with that group, they actually implemented that outpatient hysteroscopy unit, which I hope I had an influence on because it was, he learned it here. And what they found was, again, avoiding OR cases and overall healthcare savings of $500,000 in total per year. So better care, quicker care, and cheaper care is possible for women and the right care. So that's it. I'm going to leave you with some resources. heavymenstrualbleeding.com and yourperiod.ca are fantastic. Please go visit them and take a look. It's been a pleasure to be part of this meeting, and also for Carmen and Paragi to invite me. It's an honor. Thank you so much.
Thank you, Dr. Singh. I continue to learn things every time I talk to you, and with everything you say, I know there's a mission here we need to serve in this united way. And thank you for exciting me. And I think you have excited our group as well, because we have questions. Are you ready?
I'm always ready when it comes to this topic. Yeah.
Excellent. So one of the questions from our viewers is, if patients get early treatment, will the risk of fertility issues reduced?
The easy answer is yes, absolutely. I think it just totally makes sense that if we were able to stop the disease process early on, that we would be able to prevent the damage to the ovaries, to the uterus. And that may be medical therapy early on, it may mean surgical therapy. That patient I gave you the example of 68 fibroids, had we caught them when they were smaller, maybe we could have made a difference. But the problem is, because of the lack of investment in research, we actually have very few people who are looking at prevention even early on. Like if I know that this patient's mother had this many fibroids when she was 15, could I have done something to help her prevent it? That's where the ultimate goal and money should be being put. There are a couple of my friends are looking into some markers to identify and to start treating early. But at this point, for now, the answer should be yes, because you want to identify it before it gets out of control, both for endometriosis and fibroids and other conditions. And age means everything when it comes to fertility.
Thank you. One of the questions our viewers also had is whether or not pelvic floor physiotherapy is a part of your multidisciplinary team approach.
Absolutely. I think, again, the topic was an overview. There is no I-in team for sure. And one of the things when we come to chronic pain or pelvic pain, actually prolapse or anything else, you need to get as many practitioners together. And pelvic floor physio is by far the single most important intervention that we have introduced over the last decade or more. And I think every gynecologist who learns about it, who doesn't refer at this point, once they do, they see a huge improvement in symptoms. So the main thing pelvic floor physiotherapists do, and again, find physios who have trained in this. And there's a couple of excellent resources that we can also share with your website afterwards of how to find the right physiotherapist because they need extra training. The number one thing is to educate. Number two, then provide guidance, the things patients can do at home. You often can just start with one visit just to get the education part down if money is an issue. And finally, directed treatment for pain or prolapse or whatever is necessary. The challenge, Carmen, is we need to advocate that that's part of the package. How come in most part of the country there's no access because of you have to pay for it? In a full healthcare system, which is supposed to cover everything, we don't have access to that, and that's a huge barrier. So we need to cover physio and specifically pelvic floor physio.
So Dr. Singh, you said gynecologists need to refer to physiotherapy, but that physiotherapy can come from our family practitioners as well.
Absolutely, yeah. So I think, so step back, patients can even see a physio on their own, right? And for coverage or other reasons, any practitioner can do it. What I was trying to infer is that in gynecology, I was never taught about pelvic floor physio. And so that's where the information, we need to teach gynecologists that they can and that they should talk about it. And then the second point being that I've made a mission that we actually have a physiotherapist teach our residents in their curriculum now.
Excellent. So this is more of a technical question. Can endometriosis be missed during a laparoscopic surgery? If not endometriosis, then what else could present with the same symptoms?
Oh, that's a huge question. And if you go to my YouTube channel, I have a talk on chronic pelvic pain overall. So again, it's very important to be honest and direct. Can laparoscopy miss endometriosis? Absolutely, yes. Because I'm not convinced we're at the point where all of our practitioners are aware of how to look for it, identify it. So that's, again, our issue that I feel a moral responsibility to educate others. Number two is some endometriosis can be very difficult and imaging is required. But the problem is the high quality imaging you need for endometriosis is very rare to find across the country. Something I developed in my center 10 years ago, working with radiologists and our own gynecology team. And now there's growing interest in this with one of my partners who's returned from a same fellowship that my radiologist had done in Australia. And so there are many people who are interested in looking at imaging to be a little bit more clearer as to where this disease could be hiding. However, having said all that, if there is no endometriosis on any of those things, or even if you do find endometriosis, this is the crazy part of this disease or this issue, is that chronic pain comes from many sources. So it's a long discussion and it requires that the practitioner look at everything. Carmen, I'll tell you, when I see a patient who's referred for endometriosis, we uncover so much more. We have abdominal wall and pelvic floor myalgia, so muscle and nerve entrapments. Many patients I've diagnosed alongside with Ehlers-Danlos, which I've been taught always, it's a rare diagnosis. The number of patients with this rare disease affecting women in a higher number that I have in my practice doesn't make it rare anymore. Bowel issues, bladder issues, overall other issues, hip issues. So bottom line is, this is a big topic, but it requires that you find an advocate on your side. You're the first advocate, so learn as much as you can. Our YouTube video goes over some of that, but then work with individuals who can help you that way.
I have put a big star by diagnostics and imaging and quality of imaging as something that we need to move up on our radar, because it really does start with understanding what condition a woman might be facing. So thank you for bringing emphasis to that. A few of our questions have come through about early presentation of symptoms, specifically endometriosis and in other things. So can we just talk for a moment about what advice you might give to the clinician, the parent, the young girl who is, 12 to 15 years old, who is going to be treated more like a teenager than a patient? And so when you talked about that methodical process to go through, what advice would you give them to have a better conversation about this and maybe get this detection early?
Before I answer that, I just wanted to make sure I was very clear about the diagnostics, to give you the example why I'm glad you started. A normal imaging finding, so a normal ultrasound does not exclude your experience, or it does not exclude the diseases that may lead to your experience or the pain experience. And that's, Carmen, I'll be honest, when I was taught as a resident, when I was seeing patients with pain or symptoms and emerge, I remember a practitioner saying to me, and they were just as frustrated and lost. They said, hope that the ultrasound just says normal so you can just let the patient go. And my question was, but we didn't do anything for the patient. How are we going to help them? You know what? We can't. So hope that the ultrasound is your way out. So that's how bad the imaging issue is. And it has to be, I'm glad you're going to highlight it. And it has to be better. Back to the young patient, which again may experience some of these symptoms, some of these dismissals, is when I think of my younger patients that I've now grown older with as well, throughout their lifespan, there is a lot of support that's required on every level. So you have to deal with understanding what are some of the conditions that can lead to the problem, how to think about managing all of them, not just one of them, working with the family, working with the parents, and their social situation, if they're in a relationship. And I found that that's what's been the most helpful, is to look at making sure that that young person with their family, if that's who's advocating for them, find practitioners who are willing to work with them and move forward in educating them. There is seldom going to be one simple answer to everybody's issue. So that's very important to consider. Yeah, you're better in focus now. Perfect. And so I think it really matters that we have a full discussion. One warning I'll give that I've seen a lot on the internet is that if anybody promises you the world and one cure for everything for everybody, there is no one size fits all. And I think that you have to be aware. So if somebody says to a 16-year-old, and if it was my daughter, that I'm going to do surgery for you and that's going to cure you of your lifelong history of pain, that is not accurate, because they haven't even examined the patient. They haven't even evaluated the patient. There's no single pill or medication. So at that age, it really does require an advocate who's going to go with you the whole time along. So acknowledgement, workup, right? Better imaging if needed, or evaluation, understanding of pain, and multi-system approach. Often in younger patients, the bowels are affected as well, the bladder, the stress, the anxiety around school, missing school, all of that has to come into play. Sorry, I spent a lot of time on that one because it's a big one.
Well, and we're committed to changing future generations and behaviors, attitudes, and addressing bias. And I think our next generation will make it easy easier to do that, but we're going to live with the current generations for a few more decades. So we're pushing on both ways. So thanks for spending that extra time. You provided an infographic on self-management for endometriosis. And we have a couple of questions relating to self-management, supplements, and the effects of diet and exercise. So what's the holistic approach to living better when you're dealing with these chronic symptoms of heavy bleeding, endometriosis, fibroids? Does that endometriosis infographic apply across the board? And is there anything you'd add?
I think one of the things that we've understood during the pandemic, and I'm very honest with patients, I practice mindfulness to keep my mental health in check during a very difficult over a year now. And I encourage everybody to recognize that when we're struggling with whatever comes our way, we have to take control. We have to be an advocate for ourselves. And that means making sure that you eat well, that you exercise, that you practice mindfulness for stress reduction, which is a common theme, and that seldom is it going to be that there's just one simple pill or cure or supplement. And I think that is very important from our perspective. And I get worried that the multi-billion-dollar supplement business, which has no evidence for the most part, continues to prey on our communities simply because we failed them because of lack of access. So they can't see me or my colleagues in time. You know, we haven't got them access to nutritionist or a physiotherapist, and yet there's a promise. So for some reason, maybe your Facebook feed does this too. I get somebody keeps posting on my Facebook, for every condition I talk about, it's the same response, that they will cure with a special herbal supplement. And honestly, if it was there, I would be promoting it. But we have to be careful. So the simple approach for me for managing things is take control of those things you can take control of. It's like the serenity prayer, right? And we have to accept those things we can't change, but you have to come to the table prepared. Any athlete will tell you that, any person in a workplace, you have to have all of those things in check. And it's not hokey pokey. We're not saying it's in, you know, when I do mindfulness, I don't think I'm, you know, being labeled by saying this stress that I've experienced and the chronic pain in my neck I experienced from operating a lot when we reopened. But I needed to manage some of the expectations as I went to physio, as I did other things. So on top of that is the medical and the surgical interventions, but it's never one thing. So I think it is important to look at that, and please be careful of utilizing treatments that haven't been proven. I have patients who will often tell me they don't have enough money for physio, but they're spending thousands of dollars on supplements. I have patients who said they can't afford the medical therapy we're talking about, which may be about $40 a month, because, you know, but yet they're on tons of lists of medications prescribed to them by, you know, their naturopath or homeopath. And I wasn't as open about this in the past, Carmen, because I was always trying to be very supportive. But when my patients were struggling and didn't see the change and the evidence wasn't there, then I just simply felt they were being taken advantage of. So I think we have to be careful. So if you got the money, do it. Those are my 2 rules. If it costs too much, don't do it. And if it's going to kill you, don't do it. Those are my rules. I'll support that. But at the same time, let's be honest and realistic about what expectations are there. But it's because we failed them as a medical system. Your approach to navigating the system better, that is what needs to happen so that they can finally get to the best place for the best care.
I'm very grateful for that explanation. Funny enough, I had a conversation with a woman just 2 days ago where she finally opened up about incontinence. And I said, you should, you know, watch our video that's on our website and then go see a physiotherapist. She said, but I don't have coverage. I can't pay for a physiotherapist. And I said, but I know you go for a massage every week. Maybe just switch out one of those massages for a trip to the physiotherapist. And it had never occurred to her to prioritize her uterine health with as high a priority as her as getting a relaxing massage. So it really is about talking about it. So now we have a couple of navigation questions, so I'm glad you brought that up. What would sorry, I'll do this one. Where would you recommend a patient go if they are looking for pay out of pocket for excision surgery?
So Carmen, we've got to get you in the know. So whoever's written that question is in the know. And again, I have nothing to gain or to lose by being very honest with my opinions. The term excision surgery has now become synonymous with the ideal management for endometriosis care. And a lot of it comes from a push from private surgical centers that feel that this is a way to touch base with patients, and then they can care for them, but just to do that. So before I go back, everything I said holds to this. Care for those suffering with chronic pain and other conditions needs a holistic approach. So to travel somewhere else, including to Ontario, where I've had patients, is never enough to really manage the whole issue. And so some of the top surgeons in the world that I work with out of Europe tell me that when patients visit them, they're so frustrated because they do a great job, but then they don't have physio back at home. They don't have that support. And so we often hear of patients who are going back every 6 months for excision surgery, cutting out endometriosis. So that's the bigger talk, is ideally you would find holistic care, and that's what, Carmen, we have to do here in Ontario, or sorry, in Canada and Alberta. The issue is that when you're looking for people outside of Canada to pay, currently that's up to you to look into, but just beware. Anybody who's promising you the world, be careful. And so I'm not going to endorse anybody or anyone. And ideally, it would be a center which looks at it holistically. My dream would be that we would have our own Canadian center. You spend 2 weeks, not in hospital, but in a healing therapy place where you get physio afterwards, you get mindfulness training, you get yoga and exercise, nutrition training after your surgery is done, if that's what's indicated. So bottom line, not going to endorse anybody specifically, because I think that it may be the right answer for some, but please be realistic in terms of what you're looking at. There is no perfect solution out there.
So can you offer a clarification to me? I know that there has been an emergence in Alberta and probably across Canada of private clinics, or they're sort of hybrid clinics that are specializing in women's health. And so are you saying, is this excision surgery available through clinics in Alberta now, or is that something different?
Not that I know of through a private setting. So the individual, there's and excision surgery varies, right? So the stuff I see is all the really bad bowel, bladder invasion. Like you need a full-on academic center, because I work with my thoracic surgeon, my general surgeon, et cetera. So there may be clinics that offer straightforward laparoscopy, but what that person I believe is referring to is in the US, there are many sites you can go onto now, and for a low fee of between $50,000 and $150,000, they will do your surgery for you. And that's what they're referring to. And again, I'm just being honest that my concern is for your group to understand that if I've got so many patients and I operate 2 to 3 times a week, a center in the US, which should be super busy, how can they possibly have that much room for others? So, and I would send patients, number one, if I knew there was a place that was going to do that holistic approach. And to be honest, there is none right now that we have.
Thank you for that clarification. And if the individual who asked that question doesn't feel like I've hit the right marks with how I posed that to you, I would encourage them to send a note through the chat box again, and we can keep this conversation going. Again, a very particular question, and I'm mindful that we're going to be running out of time soon. What is the best way to navigate the healthcare system for a woman with endometriosis who is struggling with fertility?
So this actually relates to the other question, because I don't think so I answered the question about the fact that we can't advocate, be careful, spending a lot of your money. Many of the patients who've gone to those private systems, I've seen in the back, and then they go back again, or eventually we have to take care of them in one way or the other. Fertility is the same. Fertility and endometriosis require a multidisciplinary approach. You should, ideally, if that's the issue, you want a fertility doctor as well as an endometriosis specialist chatting with you to preserve them. Excision surgery for somebody who wants fertility, and if they don't have pain or other organ involvement, may not be the right answer. It might be trying to help them get pregnant through fertility treatment options. So each person requires an individualized care plan. And what I want to say to both those questions is advocate for yourself. Yes, I do refuse referrals right now because we're overwhelmed. And my partners may have long wait lists, but all I can offer is if you were my sister, you were my wife, you were my family member, I would be advocating, learning, and then making the phone calls. That's as best as we can go until Carmen and group develop a navigation pathway to the right way of doing this. But for now, yeah, advocate, ask for help, talk to others, talk to your family doctor about getting a referral. And if you don't get the answers you want, speak up for yourself. We've accepted that it has to happen, especially if you're not doing well.
So our viewers, one of our viewers, and I suspect this is on the minds of all of them, what are the top websites, books, resources you recommend? I'm going to follow up with you on that after this session and build out some resources on our website. But as a takeaway for the people that are online now, where would you send them to make sure that they can gather the right information to go and have a better conversation with their doctor, take authority over their health experience, and be the leader of their treatment team?
So, I've already shared a couple of them. heavymenstrualbleeding.com, yourperiod.ca are a couple of the really good resources. But I do like, as we all get a bit older, Jennifer Gunter's books. So she's a fantastic individual. She did residency where I did at Western University. We wrote a paper together way back when, but she wrote a book about menstrual health, and now has done one on menopause. And so very accurate. Follow her blogs. She's no BS. She'll call out people who are making stuff up. And she'll be honest and at the same time very accurate. And her 2 books are excellent. And I've got a couple of extra copies. If somebody's nearby, I can drop them off for them. But her books are great. Her blogs are great. And so find trusted people who can do that. Ultimately, I think, Carmen, the challenge also comes back on us. We're busy with clinical work, but we need to create better resources. I need to have a better website than my university site so that patients know that they can get accurate information. And because we're not in a private system, so I make most of my money from doing surgery, but it's a universal health system, so I don't want more business. I'm not advertising. So the motivation becomes just trying to keep up with the backlog, not trying to promote anything, but what we have to do is promote better health. So we need to work, and if you guys can do it and we can give you the resources, then that's perfect.
I think that is a great way to, begin to wrap up this session. And I'm glad that you have kept the door open to, as I said, build out those resources, that kind of thing. I see in the chat box that we shared a link to Dr. Gunter's Vagina Bible book, which I also think is a great resource. And it is Women's Health Week. And what we're encouraging people to do is read a book, watch a podcast, read a news story, and then turn to your friends and your colleagues and your family and have really open, bold, provocative conversations about it, because it is, I continue to be shocked that I will open up a conversation with almost any woman, and within minutes, we can have a more bold conversation. We can talk about incontinence. We can talk about the fear of laughing too loud or jumping too high because, we might have an accident. We can talk about that time we had to leave work because, our periods caught us off guard. But somebody has to be willing to start the conversation. And one of the easiest ways to start conversations is to talk about something you've read, heard, watched. And that's what on our womenshealthweek.ca, we have several recommendations, and several of them are from Dr. Gunter in terms of podcasts to watch and that kind of thing, and then go talk about it. So I think we're going to finish with you now, Dr. Singh, on behalf of the Women's Health Coalition. We would like to thank you for your time this morning, for all of your expert advice. You have been an amazing advocate for women's health in all of the stuff that has happened with government over the last couple of weeks. And I don't know how you found time for all of it, but I know I could not have gotten as far as I did without you. We will be creating a summary document that we can tell all of Albertans how much progress we're making already. It really is quite remarkable, but it's because women are telling their stories, healthcare professionals are making sure we get it right, and the government and health system influencers are open and excited about new approaches. And so when we put that formula together, we know that it can look different. We can be in a different place in 5 years. And in fact, that was Minister Chandro's challenge, right? Tell me where we need to be in 5 years and how can we work together to get there. So anybody whose question didn't get answered, please know we've captured them all. If you have any questions after the session, please send them to the info@thewhc.ca and we will follow up. This relationship with Dr. Singh doesn't end today. So, as he said, those resources are still available. So we want to keep bold conversations going. Our next webinar will be held on June 5th, I believe it is. I might have that date wrong, but you can find it on our website. The topic is the ups and downs of sex, a focus on factors influencing sexual function in women's health. Dr. Harushka is an expert and a local celebrity. I know many people talk about hearing him on the radio, and he gets brought in as a guest speaker, but his specialty is in working with a wide variety of sexual issues, as he is a certified sex therapist, diplomat of sex therapy, and clinical psychologist. Nobody is going to want to miss this provocative conversation about women's sexual health. If you missed them and you are a member of the WHC, you can also view any of our webinars on our website. We've made them open to everybody as we've been getting ready for this Women's Health Week launch, but in just a few days, that will become a private members only section and resource on our website. And the reason for that isn't to limit access to the resources we want to share. It's to ensure that we can grow our movement, to make sure that we have a following that we can demonstrate to government and health system influencers that prove that we are providing evidence-based recommendations. And so that's why we are encouraging people to become members of the Women's Health Coalition. And so, like I said, look at those webinars soon, because before long they will be under a members only site. And so I hope it will encourage you to become a member if you're not already. At the beginning of the opening remarks, I said that I wanted you to meet the Women's Health Coalition team. It is absolutely astounding that we have accomplished as much as we have in such a short period of time with only volunteers. We have no staff support whatsoever, and it's been the generosity of business leaders and community leaders and businesses and that have made all of this possible. But turning the corner on our advocacy efforts has come from the tireless efforts of our volunteers. And they, for today and for the week ahead, will be wearing their Wear Red Period t-shirts to show that they are standing up for women's health. And for anybody on the line that is a member, we will be having a member celebration and a Women's Health Week reflections event, of course virtual, on May 15th. That will be at the end of the week, and you may have to bring your own wine or whatever your beverage of choice is, but the celebration will be one we'll do together. So thank you to all of the Women's Health Coalition volunteers. You are a rock star team, and I can't wait to see what lies ahead. And I've said already, if you're not a member, I hope you become one. If you are a member, I hope you will volunteer with us. There are so many opportunities. If you're a healthcare professional, you may want to consider getting involved in our Foundations for Women's Health Leadership Council and Advisory Network. That's how we will inform our work with expertise and evidence. And there are endless opportunities to be a part of this movement that is so important that it go get on fire right now. So as I said, I'm Carmen Whiten. You can email me through info@thewhc.ca, and I look forward to connecting with everybody, and stay tuned for this webinar to be posted in a few days. Thank you.